My name is Dr. Anoop Agrawal. I am an interventional cardiologist here at CARE Hospitals. My area of expertise includes critical care cardiology, interventional cardiology in adults, as well as transcatheter aortic valve implantation. Today we are discussing about one of our patients. Ms. is a 65-year-old female who originally presented to us with breathing difficulties. She had a previous mitral valve surgery done about 5 years ago for myxomatous mitral degeneration. At that time, she did fine, but in the last few months, she had been having worsening dyspnea. On evaluation, she was found to have severe aortic stenosis, which needed further intervention. We discussed with Ms. and her family about various options. So whenever a patient like her presents to us with severe aortic stenosis, the management options include medical therapy, surgery versus transcatheter aortic valve implantation. And here we know that medicine in her case or in any severe aortic stenosis has very limited utility. So the options that we are left with is surgical aortic valve replacement versus transcatheter aortic valve implantation. In her case, we had a long discussion with the family as well as her referring physician. So few things in her clinical scenario made it difficult for a surgery. First of all, because of her previous mitral surgery, this would be a redo sternotomy. With her frailty and her growing age, it was perceived to be a higher risk than usual to undergo another surgery. On the top of that, she has a long-standing rheumatoid arthritis and she's on disease-modifying agents along with steroids, making her immunocompromised. On the top of it, with her frailty, it became difficult for her to undergo surgical aortic valve replacement. So we discussed at length and we decided that TAVI or TAVR, which is transcatheter aortic valve replacement, was the best option in her. At the time when I saw her, she was doing otherwise fine. She did complain of class 2 to class 3 symptoms, and most of her evaluations were quite feasible for a routine TAVR case. Hello all, my name is Anoop Agrawal, and we have a TAVR case today. Let me introduce my team first. So I'm the cardiologist here, and to the right of me is Dr. Rajiv Menon and Dr. Saru. To the left of me, we have Dr. Anuj. The other team members include Dr. TVS Gopal and his team member with the anesthesia. And we have Dr. Chandramukhi and Dr. Neelkant, who is helping us with the echocardiogram. So our case plan is pretty straightforward. We have a temporary pacemaker wired through the right internal jugular. We have our primary arterial access through the right femoral, and we have a secondary access from the left femoral. As per our CT scan, our measurements are very good. It will accommodate the inline sheath, and if needed, it will also accommodate the 18 French sheath as well. Her aortic measurements are quite commensurate with the 26 millimeter Evolut R. That is what we are going on with. She has got a tricuspid valve with not much of calcification, so we are planning not to pre-dilate. We'll directly deploy the valve. And if there is mild plus aortic regurgitation, then only we'll post-dilate, otherwise we'll come out. We are continuing with a complete percutaneous approach, which means we have already fired our perclose, and if things go fine, we will simply cinch the suture and come out. So that's how. So we have the 9 French access in the primary site. We are gonna first place the pigtail on the non-coronary cusp, cross the valve, and then over a stiff wire, we will put the inline sheath from the primary access site. Okay. So straight wire and pigtail. Curve wire, J wire, sorry. Okay. Okay. All right, that's good. Hold the wire, please. Inject. Looks pretty good. Looks pretty good. Okay, so that's actually a very good shot there. Our catheter is in the non-coronary cusp.
I thought with RAO we would get further out. There you go. That's beautiful.
I see one post. I see the other.
I think it's a good low.
Yeah.
I saw both tabs there.
Yeah.
Beautifully.
Yep. So we have this confida loaded on a 6 French dilator because the cheater on the confida doesn't allow a smooth entry. So we always use this dilator to make our way through.
Straight rail.
What you do is just hold it and push.
Okay. Okay.
Beautiful.
Confida is right at the place. It is at the apex, which is where we like it. And our valve is all ready. So what we'll do is we'll dilate the track first, and then we go with the valve system. Okay, so my inline sheath is in place. Very, very comfortable now here. Now we're going to track this. So just follow. Follow with the II, please follow. Okay, now we're going to pause here. We'll go LAO. Okay, so push in wire just a bit, because in a second I'll tell you to pull it back slightly.
So it's a little more arch.
Arch ऊपर दिखाइए और ऊपर. हाँ, that is good. Okay, now gentle tug on the wire. Show me the distal wire as well, the wire in the LV as well. That is good. Yeah, gentle tug on the wire. So this arch is slightly. Yeah. Yeah. See if you can go some more LAO. Yeah. Okay. All right.
Go back to your working view.
Okay, that is good. All right. Inject. So we are deploying. Okay, go. 1, 2, 1. Keep going. 2. So we'll go till we flare there.
See the cap?
Okay. Keep going slowly. Keep going till the time it makes annular contact.
So it'll slip in. So
Keep
start
going.
to add a little back pressure.
Yep.
There.
Yep. I'm doing it.
See
Keep
that?
going. Okay.
Go slow. Stop for a
Slow.
second.
Let it release all the
let-
way.
Well, we pace at 120.
Okay. Let's pace at 120, please. Okay. We are going to give a gentle push on the wire to make sure it aligns properly. So just a gentle push. Okay.
So now let's roll slow.
Okay. Go slow again. So we lose pressure here for a second. Keep going. Slow.
Keep rolling. Keep rolling.
Okay.
You can roll it all the way. up
Yeah.
to the
Now you
rumble.
can go fast. Show us the upper part of the arch,
Roll
please.
to the rumble. Roll to
Upper
the
part of the
nose.
arch. Keep going. Keep going. One more.
Half a roll.
And that's it. Inject.
I think you push it
Keep
just
rolling.
a little bit more. Okay.
Yeah, I'm pushing already.
Yeah.
Okay. Roll.
Stop there.
Okay. Stop.
Now push in. Because it's going to come
Yeah.
off the tabs if you push in.
Okay.
And roll
And
another
roll just a bit.
Roll.
Just a bit more.
Half a roll.
Just a bit more. And
There
that's
you go.
good.
Very nice. Awesome. No
So
gradient.
our scale is 200. We have no gradient. Our LV systolic pressure is about 146, and aortic systolic is again 146. Diastolic pressure is about, here we are getting about 50, and EDP of still about 18 to 20. So EDP did not rise, and our diastolic difference is still about, this time it's about 30 millimeters, 25, 30 millimeters. So we're pretty good, zero gradient. We have got nice dichrotic notch there. Inject. So there is certainly some regurgitation there. Okay, inflate. Deflate. Keep pacing. Balloon out. Balloon out. And stop pacing now. So now the aortic regurgitation is lower than before, at least angiographically. Do you agree? Put this in there. No. You go in just with the with the blue one.
You don't want the white one.
No, just go in with the blue one. Park your plunger nicely. Okay, now you put your thumb in there, and now you lock it. Okay, this is where I inject.
Perfect. Little constriction, which
Yeah.
you
Yeah.
expect to see.
That is nice.
But
So we just finished our procedure. We did our per close on the primary access site, and we did a one single per close on our secondary access site. All looks good. We did an angiogram after our per close, and there is no leakage, there is no bleeding at the primary access site, so we are pretty good there. Right now I don't see any oozing. We have not done heparin reversal. Our ACT was slightly on the lower side, and there is no oozing. So we decided not to give heparin reversal. All in all, things look very good, and I thank everybody who participated in this case. Today's procedure of TAVR for Mrs. was pretty much as expected. We brought her to our cath lab. We did the procedure under general anesthesia. which our anesthesia team decided that she was a very reasonable candidate for it. We got our usual accesses for vascular, for arterial as well as venous. It was a complete percutaneous approach. We deployed the valve as expected, and we were able to finish the procedure in a complete sutureless fashion. We did perclose cinching on both the arterial sides with no skin suture whatsoever. Patients like her, they do very well after TAVR, particularly with a procedure as good as this one. She will be monitored in the ICCU for about 24 hours, where we'll be monitoring her groin, we'll be monitoring her delayed conduction abnormalities and her hemodynamics. We will move her to a regular room tomorrow if everything turns out quite well, and these patients can be expected to go home on day 3 or day 4 of the procedure.